Today we'll discuss the LFU tracking, the national priority. As you know that NACO has adopted 1990 targets set by the UNAIDS that has to be achieved by 2020. So what are these 1990 targets? 90% of the PLHIV should know their status. Out of these who know their status, 90% should be started on treatment. Of those who have been started on the treatment, 90% should be virally suppressed. So as per these 1990 targets, what are exactly our targets? So as we know, we have around 21 lakh of the PLHIVs around the whole country. Out of these 21 lakh, we have to diagnose around 18.9 lakh of the PLHIV. Out of these 19 lakh to be diagnosed, we need to start 17 lakh to be on ART. Then of these 17 lakh on ART, we have to ensure that around at least 15 lakh of the PLHIVs are virally suppressed. So where are we exactly at the national level as compared to this 1990 targets? So out of these 21 lakh PLHIV estimated to be in India, around 15 lakh have already been diagnosed. So yet we have to ensure that 21% are still have not been diagnosed and they need to be diagnosed. Then more than 10 lakh of the PLHIV have been started on ART. We yet have to achieve 41% those who have not been initiated on ART. So as you can observe that there is a gap of around 5 lakh patients that has to be started on ART. So how we are going to achieve this target? So the steps that will help us for reaching this 1990 targets. First we have to identify all the PLHIVs. Then we have to link them all to the services, that is from the ICTC centers to the ART centers. Then we have to treat all. Now as you know that the Government of India has already issued the guidelines that all the PLHIVs, regardless of the CD4 count or the clinical stage or the population or the age, they have to be started on the treatment. So a proper counseling has to be done and a baseline investigation including the CD4 count has to be done for that. Then after treating all, we need to ensure that all these PLHIVs are retained in the system. How this is going to happen is, we have to ensure that we are not losing any patient after they have been initiated on the treatment. Then we have to track all. Those who have already been lost to follow-up, we need to ensure that these are tracked back, and those who are not retained in the system in the future will also have to be tracked back. We have to maintain adherence of more than 95% in the all. So to achieve this 1990 targets, the program has planned that some key indicators will be monitored for that. So in terms of quality of care, the program has planned that will monitor the retention cascade. This retention cascade, we are already monitoring it. We have to ensure that all the patients, those who are now started on ART, they has to be on the treatment throughout the life. They are retained back in the system and they are not lost to follow-up. We'll also monitor the 12-month retention. That is, we'll ensure that after starting the ART, after 12 months of starting the ART, the person is still in the system and is taking ART regularly. We have to ensure that death, LFU or miss rate are lower. We have to ensure that adherence is more than 95% in all. So all these indicators will be monitored. In terms of linkages, we'll monitor the ART centers to the care support centers linkages, whether the patient has reached from ART centers to CSCs, and those who have been registered at the care support centers are also registered at the ART centers. Also, we have to ensure that reporting is correct complete and timely. The correct, complete and timely report has to be ensured in IMS, MPR, PAL system and the master line list. So through these key indicators, we have to ensure that our program is approaching towards the 1990 targets. Now if we see the national patient cohort, around 70% of the PLHIVs, they are on ART. And around 30% of the PLHIV cohort is from pre-ART group. So the LFU rate among the on-ART cohort is around 9%. And if we check it in the pre-ART cohort, we have around 29 plus 22% of the PLHIV who are lost to follow-up. So it comes around 51% of the PLHIV cohort from pre-ART group is LFU. So the retention among this pre-ART group has been very poor, and with the treat all policy, we'll now need to focus to convert these pre-ART patients to ART, and this will further reduce the loss to follow-up among the pre-ART group. Now if analyze the retention cascade of the last financial year, out of around 1,70,000 patients who have been registered in the last financial year, we have PLHIV have undergone baseline CD4 testing is 94% only. So we have lost here around 6% of the PLHIVs whose baseline CD4 has not been done. And among those who are eligible for ART, only 89% have been initiated on ART. So here also we are losing around 11% of the people who has to be started on ART. When we analyze the IMS data, we observe that the PLHIV who are retained after the 12 months is only 71%. We are losing around 29% here also. So after every 12 months there is a loss of 30% of the patients. Also, when we analyze the 6 months pill pickup behavior at national level, we observe that around 35% of the Indian PLHIV who became miss within the first 3 months. If you see it, like first 3 months, there is only 65% of the PLHIV who are on ART, and we are losing every 3 months the 35% of the PLHIV. So here we need to note down that in the retention cascade, we are losing around 11% of the PLHIV who are eligible but have not been initiated on ART. For around 6% of the PLHIVs, we have not done the CD4 baseline testing. Then among the ART group, we have around 9% of the PLHIVs who are lost to follow-up, and in among pre-ART group, we have around 51% of the PLHIVs who are lost to follow-up. So with this much of data, are we able to achieve this 90-90-90 targets? So the answer is no. We will not be able to achieve this 90-90 targets. So we have to work on this data to improve these indicators of our program. So for this only, the program felt that there is a need for LFU drive through which the LFU patients can be further tracked back to our system. So what were the reasons for LFU drive? That the LFU was not showing any desired declining trend nationally. There were around 5,66,000 LFUs which have been reported in March 2017. It includes both the LFUs as well as the miss cases. Every month, equal or more number of the LFU or miss cases are added to the LFU line list than being brought back by the CSCs. Also, it was needed to ascertain cases that were completely untraceable, and hence it was impossible to bring them back to the treatment. Keeping all this in context, it was proposed that the NACO and the VIHAN will jointly carry out an intensified LFU tracking with a collaborative commitment to work towards reaching, tracking and linking back the loss to follow-up. And will also work to prevent the new miss or LFU cases at the ART centers so that we can achieve the 1990 targets. So what is the objective of the LFU drive? That we wanted to firm up the traceable LFU line list across all the ERT centers in the country and to prioritize the LFU cases for effective tracking and get back the optimal track back results. So what was the principle that we had planned for this intensified LFU drive? For the LFU drive, we have thought that we'll prepare a complete line list of the patients who are LFU reported till January 2017. So for this, among the list, those who have been reported till January 2017, we'll segregate this list among the shared with CSCs and not shared with CSCs. Those who have not been shared with CSCs, they will be further followed up through the contact drive, and among those who have already been shared with the CSCs, we'll further segregate the list among those who have already been contacted by the CSCs and those who have not been contacted by the CSC. Those who have not been contacted by the CSCs, that they will be followed further by the contact drive. For the already contacted by CSC, the list will again be segregated of those having the definite outcomes and non-definite outcomes. Non-definite outcomes, like the person have the incorrect address. So this kind of feedback will further be shared with the CSCs for the contact drive. Then among the definite outcomes, like having the person has died or the person has transferred out, for these outcomes the list will be shared with the ART centers and the outcomes will be updated in the records. Further, the contact drive's outcome will again be shared with the ART centers for the updation in the records. So what are the detailed activities of the LFU drive? I just noted down that there is a question regarding to how to prioritize this drive. So this question will be shortly dealt with. I'll answer this question later. Now we will discuss about the LFU drive, how the detailed activities are. First, the ART centers will prepare a line list of all the LFUs, including the 2.7a, 2.7b and 2.9 indicator in the master line list format, and this data will be reported till January 2017. Now this list will be collected and compiled and will be sent to the NACO by SACS. NACO will further share this list with Alliance India. Data cleaning will be done by Alliance India, and after that the feedback which have been received by Alliance India will further be shared with ART center by NACO. The ART centers then have to complete the line list as per the NACO feedback. The ART centers will also cross-verify the CSC's feedback given in the tracking outcome format. So after cross-verifying the data from the CSCs and updating as per the NACO feedback, this list will be shared with the NACO, and NACO will further share it with Alliance India for segregating the data among contacted and non-contacted. Those who have been contacted have already been received feedback from CSCs, but for those who have not been contacted or they have agreed to visit earlier but didn't came back to the ART services, for these cases further contact drive will be done. Then NACO through SACS and Alliance India will firm up the LFU data based on the validated outcomes. After this, the updation will be done, the updation of the outcomes will be done by the ART centers and the ART center records. So this is the brief summary of the procedure, how the LFU drive has been planned. We have also received queries from the states regarding how the reporting after this post January 2017 will be done. So to answer this, the ART centers will only share the list of the new miss LFU or eligible but not initiated on ART from Feb onwards in the tracker sheet format, and will update the feedback received from the CSCs in the IMS white cards and registers. So Please note that only the new miss or LFU cases after the February 2017 have to be shared with the CSCs. The reporting under the section of 2.78, 2.7b and 2.9 has to be the same as previously done. As you were previously reporting in the MPR, it has to be the same data. But under the section 3A, as per the new MPR, you have to fill this data as per the 3A section. 3A1 indicator, you have to mention that the number of the patients whose lists have been shared with Vihan in the month prior to the reporting month. So if you are reporting in the month of the March, so the list that you have shared in the month of the February, that number has to be written in this section. Then 3A2 section, out of the 3A1 section, number of the patients who have successfully been contacted by the Vihan, that has to be entered in this section. Then under the section of 3A.3, out of the 3A.2, number of the patients who have been linked back by the ART center, linked back to the ART centers has to be entered. So where are we in terms of the present LFU drive? NACO has already received the line list from all the ART centers till the January 2017, but there are few centers whose list we have not received yet. So I request hereby to those centers to please submit it at the earliest. Then center-wise feedback has been shared with all the ART centers for the corrections that they have to make in the master line list. The centers need to incorporate the feedback received from NACO, as well as they have to cross-verify the line list with the CSC tracker document. If the CSC tracker back information is not updated in the ART master line list, then the data manager has to ensure that this is updated in the same line list and is submitted to the NACO by 31st May 2017. Please ensure that this list is shared with NACO by 31st May 2017, as we have to further track back all the LFUs. So please ensure that timely submission of the reports is done. Then now we'll discuss like how we'll incorporate the feedback received from NACO in the master line list. NACO has shared an Excel workbook with different Excel sheets depending on the correction that is required for the center. I'll briefly explain what each sheet means. The first is the name missing sheet. In this, the details of the PLHIVs for which names has been missing, that has been shortlisted. Then if the data manager is able to find the names for these patients in the ART records, then the data manager has to enter in the data cleaning outcome as a name updated, and if it is missing, then it has to be entered as name missing. No detail sheet have the list of the patients for which details are missing, like pre-ART number is not there or any pre-ART status is not there. So those details has to be filled by the ART center. Then in the duplication sheet, this sheet have the details of the possible duplicate entries. So data manager and counselor has to cross verify this data with the ART records. After verification, if there is a duplicate found, then one of the cases you have to mention it as a duplicate, and for the other case you can mention it as updated. For the single address or no address sheet, this have the details of those entries which do not have a proper address, or address is written in only in one word. So this list is not a traceable, it doesn't have the traceable address. So please check the ART records for complete address. If address is missing in the ART records, then please check with the CSCs for complete address. If the address is not available at CSC as well as ART centers, then together as a team, please review it and decide whether it is possible to trace the client in the given address. If it is not possible, then mention in the data cleaning outcome as address is missing. For the no due date, this have the details of the entries where the last date of the visit of the patient is not been mentioned. So you have this data is very important for us as we have to prioritize this LFU patients. So please ensure that from the records this due date is available and is been entered properly in the revised line list. If this detail is available to us, then we will be able to prioritize the tracking of the LFU. Then we have other sheet naming as status in ART missing or unknown. This have the details of the patients for which the ART status has not been mentioned. So you have to cross check your ART records, and if it is available you have to update it. Then there are some other sheets for which no updation is required by the data manager. These are basically to help the CSCs to do outreach activities. These are the same address having the patient details who have the same address. Other state sheet which have the details of the states which have the details of the PLHIVs which are from other states. And then after 2016 data, that is the data which have the details of the PLHIVs that are lost to follow up after 2016. So data manager has to ensure that this client list has been shared with the CSCs for further follow up. And as the question was asked that how we are going to prioritize the LFU tracking, this is the one basis of starting tracking of the patient. You have to prioritize this group of the cohort who are from 2016 onwards. So those patients who have been last visited after the 1st January 2016, that has to be prioritized for tracking back. We have some other sheets also, like main sheet. This sheet have all the details of the LFU line list with the traceable information. So the ART data manager and SR officer has to verify this line list with the CSC tracker document. If CSC trackback information is not updated in ART MLL, the data manager must update the same. There is also a sheet naming as 2010. This has the details of the clients who have become LFU before 31st December of 2010. So the ART manager, data manager and the SR officer, they have to verify that this list with the CSC tracker document and has to be updated as per the feedback given by CSC. So this is the summary how the feedback given by the NACO has to be updated in the master line list. The data manager has to add one column by naming as data cleaning outcome in each Excel worksheet. Like suppose for the name missing sheet, if the name is available then the name is entered in the sheet, and in the data cleaning outcome you will mention it as being updated. If the name is not available, you will write it as name is missing. For no detail sheet, if details are available, you fill the details in the respected columns and then you write it as updated. If no details are available, you have to write it as no details. For the duplication sheet, you have to cross check whether these entries are duplicated. If they are duplicated, then against one entry you will write as updated and against the other you will write it as duplicate. If the single address or no address is there, then you have to cross check with the records and find out the right address. If a right address is available, you write it as updated. If address is missing, you have to mention it as address missing. For the no due date, you have to ensure that the last date of the visit is available. If it is available, you fill the that details in the due date column and you write it as updated in the data cleaning outcome. If no due date is available, you write it as no due date available. Then in the sheet naming as status in ART care missing or unknown, you have to fill the details as per the status in the ART care and you have to mention it as being updated and if not available, missing. I'll just show an example of how it has been done by one of the center. As you can see, the data manager has added one column here naming as data cleaning outcome. For those whose address was not available, here the details are missing, so the person has written as address missing. But where the data address was available, that address has been added, the contact number of the person has been added, and it has been mentioned as updated. So this is how the feedback received from the NACO has to be incorporated in the Excel sheet. So I'll just go through some questions that have been raised. It has been asked by Dinanath Yadav that all staff issue if I follow 4 to 5 times any present but they do not come due to the out of station, and if they agree to come on ART center but they don't come, then tell me, can I complete the data cleaning of the client? So I want to just ensure that for the clients who have been agreeing to follow up but are not yet coming to the center, we have to ensure that at least 2 visits are done by the outreach workers. If it is not so, then it has to be followed up by the peer counselor. Peer counselor has to go to the patient and has to ensure that patient is counseled properly and is asked to come back to the ART centers. If then also the person is not coming to the ART centers, then at the time of the LFU drive, we have to ensure that the SR of the CSCs, they make call to the people and they ensure that the people are counseled over the telephonic call and they are come back to the ART centers. And all these details has to be recorded properly so that the further outcome, final outcome can be decided based on this recordings. The next step after incorporating the feedback from the NACO is that we have to compare this LFU line list with the compiled CSC tracker list. So the working sheets, namely name missing, no details duplication sheet, single address, status in ART care missing or unknown, main sheet and the sheet with 2010 details, they need to be cross-verified and updated as per the CSC tracker list. So when you'll be cross-verifying this data, you'll observe that there will be a list that has already been shared with the CSCs, and there will be a list those who have not been shared with CSCs. For the list those who have already been shared with CSCs, the ART center has to look and update the feedback given by the CSC. For those who have not been shared with CSC, the ART center must provide this list to follow up, and CSC must complete this tracking by June 2017. So further, for the list those who have already been shared with CSC, the incorporation of the feedback has to be done by adding 2 columns. The first column is the feedback from the CSC and the other column is the date of the feedback received from the CSC. So for the outcomes like brought back, you have to ensure that the brought back date is higher than the LFU due date, then the client is active care. If this has to be updated in the master line list. But if suppose there is a possibility that client becoming LFU again, so you have to verify that the information with concerned ORW and ask him or her to follow up again. For the definite outcomes like death, stopped, transferred out, you have to enter the details like died, stopped or transferred out in the column feedback from CSC. For the indefinite outcomes like incorrect address or incomplete address, you have to record the same as incorrect address or a migrant in the date feedback from CSC. Then the others reason for loss to follow up, you have to look for the feedback given by the CSC and you have to specify the reason that has been stated by CSC. So please ensure that this reason has been specified properly in the list. And then those who have agreed to visit, for this group, intensified follow-up will be done by CSC, SRs and ART centers to bring back this client. If client is not coming back to the treatment, even after 22 visits by ORW, The third visit should be from CSC's peer counselor, and it has to be motivated to take the treatment back. So as I've already mentioned, further the SR will make a telephonic call to make sure that the person who has agreed to visit come back to the ART center, and this has to be recorded properly. Sorry. Then what to record in the column feedback from CSC? This is how for brought back cases you have to mention it as brought back. You have to check the proof from the records whether the person has been brought back to the ART center or not. For death you have to mention as death, citing the proof from the CSC. For stopped you have to mention it as stopped. Transferred out के लिए you will have to mention transferred. For those who are taking medicine from private ART, you have to mention it as private ART. For opted out, you have to mention it as opted out. And those who are taking medicine from the other ART centers, you have to mention it as other NACO ART centers. For incomplete address, you have to mention it as incomplete address. For others, you have to specify citing the proper reason for not linking it back. And those who have been agreed to visit, you will mention it as agreed to visit, and if it brought back date is if already come back, and if you have to record all the procedures to follow up for this that you have taken to follow up for this patient. I'll take another question from this. It says at ART Center Surendra Nagar, what should we do when one patient registered at the other ART center with other name? So if it is in the same state or it is in this, so the person is registered at the other ART center with other name, and if the person have the same address, then we have to this line list will be cross-checked and cross-verified, and if it is found to be duplicated, then further this will be removed from the list once we analyze the whole line list of the state. So at present the ART center doesn't have to work on it. So there is a question like patient gives address as per vote card or ration card. CSC says that the client not found that is given address is wrong. What to do? For the patient who have given their address as per the voting card and ration card, and they are not able to find out as per the address is wrong, so please ensure that the patient when registered at the ART centers, the address is cross-verified with the CSCs. Once the person is registered at the ART centers, their detailed address is cross-verified, and the CSC's outreach worker to visit those patients at the ART center at the time of registration, so that you ensure that these addresses are the proper address and we don't lose the patients because of wrong address. Now we'll discuss what is the role of the SACs in terms of the tracking the LFU back. The SACs has to ensure that the joint action plan is developed with the SR for completing this data cleaning drive. The instructions are given to the ART centers regarding this drive, how they have to incorporate the feedback, and ask them to support the SR team. You have to identify the centers where additional support is required from SR or PR, and where, like suppose the data manager post is vacant or the center have the huge data, then the SR and PR can support those centers. SACs has to review the progress of data cleaning with SR program manager if possible on every Monday. It is requested to SACs to please ensure that all newly registered clients' address verification is done through CSCs. Clients who have been registered in 2015 and 2016. I'll say after 2014, their address should be available to us, as we after 2014 we have the CSE program. So at least after this period, the patient's address should be available to us. If it is not available, then it shows that we have the poor quality of the services at our centers. So please ensure that all the address details and the contact numbers for at least for the cohort of 2014, 15 and 16 is available. Then the priority number of all the clients is updated. Due date for visit of all the LFU's cases is updated. Then what the ART centers have to do? Then they have to support the CSE team in LFU drive. They have to incorporate the feedback received from CSEs. They have to cross-verify the details, and they have to, after going through verifying the supporting documents, you have to incorporate this feedback. Then please ensure that the updated line list that has the feedback received from the NACO as well as the updation of the feedback received from CSC is submitted to NACO by 31st May 2017. So what is the role of CSCs? All the outreach workers have to track back the LFUs on priority from 2016 and then to the 2015. While tracking back the clients, help the ART centers in updating the complete address, phone number and Aadhaar card of the person. The Aadhaar card of the person will sort out the duplications that are occurring if the person is registering at one ART centers and then going to other ART centers. So this problem will be sorted out. So what are the immediate priority steps that we need to take? SACS has to ensure the corrections are made in master line list as suggested. So please ensure that whatever the feedback has been given by NACO, that is being updated in the master line list. Please cross-verify the ART centers list that ART centers are submitting to you and ensure that the gaps identified are addressed and the list is as per the proper guidelines. Then the data managers have to incorporate the feedback and revise the master line list in collaboration with the care support centers. You have please ensure that feedback is incorporated as suggested. You have to add one column naming as data cleaning outcome, and then also you have to cross verify the list with the CSCs, and you have to add, for that you have to add two columns, and then you will enter the CSCs whatever feedback has been received by CSCs and the date of the feedback given. For the ART center wise data, you should tally with SRs to see that total reported LFU cases and MPR are same as case shared with the CSCs. So the report, the list that you have submitted, that as per MPR you have this much of LFU, that should match with the list that you have shared with CSC. If it is not so, then please compare it, find out the gaps where it is and address those gaps. If it has not been yet been shared with CSCs, please ensure that this list is shared with CSCs. Then ensure all the tracking information submitted by the care support centers are incorporated in the master line list. To do this, SR team will travel to the CSCs and will have joint meeting with the ART center and CSCs. Day-to-day monitoring of this process and outcomes needs to be done by SACS. CSCs too must continue to do tracking of the clients whose clients are already shared with them. Also to prioritize tracking of LFUs from 2016 and 2015 cohort. Then all the missing address and mobile numbers has to be entered. Please ensure that the CSCs make sure that the details available with them are also available with the ART centers. So please ensure that the missing address and mobile number and the Aadhaar card number is provided to the ART centers for updation. Also, you have to ensure that complete address and telephone number is collected for all the new registrations at the center. So whenever a person is newly registered at this ART center, that complete address and telephone number has to be added to that. And this also needs to be verified. CSCs can please ensure that when the person is registered at the ART center, it's a new registration, you note down the address and you visit that address along with the PLHIV if possible. Then the updated and the cross-verified list has to be shared with NACO by 31st May 2017. If this is made possible, then only we'll be able to complete this intensified drive timely. Then there is a question from Madurai ART centers stating that some of the patients are not willing to provide Aadhaar card and phone number. So for these patients, we have to motivate them and we have to explain them what is the reason that we are noting their address. Why it is important, because we'll need them to track throughout their life. They have to take the medicine throughout their life and they have to be retained in our system. So the client has to be motivated to share their details. There is another question. If the client is in rented house, then he always switch from one to another. In this case, how to find the right client address? Then I think so for these cases, the contact number is the best alternative for the tracking the person. You should ensure that the person's contact number is proper, and through that only you are able to track those patients. There is a question from ART Center Yadgir. In LSCs, they close report on 25th of every month. According to these cases who are alive in LSCs, but whose visit due date is with 26th to 30th of that month, then it comes under miss in IMS. Then how to match this data in MLL and IMS? To this question, we'll write to you shortly. Then there is a question from Devinder Singh. If LFU is this have we already covered. Then ART Mandisore, also many clients have no contact number. So if the client doesn't have the contact number, then you have to ensure that now the services are available free of cost. So free SIM card is available. The phone is also available in minimal charges. So if it's possible for the person to have that phone with him, or there is a possibility of having a phone number of a close relative that who are residing with the person, that further alternatives can be seek for. So there is also a question like, if white card is missing, then what to do? So if the details of the white card is missing, then it has to be ensured that further records are available for the records, and with the available records, of new white card is prepared for those patients. There is another question that for death cases, if the death certificate is not available, then they can take the relative feedback. I'll suggest that for these patients, you have to ensure that the other, like you can get a written statement from the sarpanch of that village, so that you are able to find out whether the person is has actually died or not. So I think so the statements from the patient relative can be like distracting, because there is possibility that the person is stating this just to avoid the people that they are coming to their home. So it has to be ensured that it is from the correct source. So to make this LFU intensified drive as a success, we have to work as a team. We have been getting regular updates from the CSCs and ART centers regarding this LFU drive. The ART centers and the CSCs, they are working together as a team. We have received updates like the teams are working on the state holidays also. So I really appreciate those efforts, and I really want to thank you all for supporting us in this LFU intensive drive. As we know that together everyone achieves more. So it is requested that please work as a team, help each other so that we are able to make this a success. So if you have any queries, please write to me on nishanako1@gmail.com. You can also note down my contact number. The further queries related to the drive,
Thank you, ma'am, for such a wonderful session. Thanks to all the participants for patient listening. I would request all participants to kindly enter the e-poll being displayed on the screen.